All right. Hey, brilliant minds. Welcome back to Neuro, the podcast that polishes your clinical prayers onto they shine. I'm Honorary Victor, your host, and today we are diving into triple short episodes featuring three brain teasing cases that test your knowledge of movement syndromes, acute stroke decision making, and high stakes cerebrovascular management. Are you ready to diagnose like a pro? Ready to back it all up with evidence? Then let's go. Case 1. A patient presents with limited upward gaze bilaterally, nystagmus on attempted convergence, and skewed deviation. The pupils are fixed with abnormal accommodation and light near dissociation. Where is the lesion? A. Ventral midbrain. B. Pons. C. Medulla. D. Bilateral thalami. And E. Quadrigeminal plate. What do you think? We are starting strong with a localization classic, one that tests your understanding of neuroanatomy as much as it does your pattern recognition. This patient presents with 1. Limited upward gaze, 2. Convergence retraction nystagmus, 3. Skewed deviation, 4. Light near dissociation, 5. Fixed pupils with abnormal accommodation. What's the diagnosis? Did you see Parinaud syndrome? Well, if you said that, you are absolutely right. This is a textbook constellation of signs that localizes to the dorsal midbrain, specifically the pretectal region and the tectal plates, which includes the superior colliculi. Now, here's where the clarity happens. Let's break down why each of these findings occur. For limited upward gaze, this is due to damage to the ventral gaze center in the rostral interstitial nucleus of the medial longitudinal fasciculus and the posterior commissure. That was a long one. Let's go again. Damage to the vertical gaze center in the rostral interstitial nucleus of the medial longitudinal fasciculus, aka RIMLF, and the posterior commissure. Now, these structures coordinate vertical saccades and are especially vulnerable when there is compression from a pineal tumor or an infarct that occurs near the quadrigeminal plate. Without a functioning gaze center, the eyes can't look up, and hence you have upward gaze palsy. The next is the convergence retraction nystagmus, and this is a strange finding where the eyes jerk back into the orbit when attempting to gaze upward, and this occurs because the vertical gaze pathways are disrupted and the convergence pathway are spared. So, when the patient tries to look up, the brain tries to compensate by activating convergence, and this leads to an involuntary jerky contraction of the medial recti, pulling the eyes inward and backward. It's a reflex gone rogue. Next is a light near dissociation, and you've probably heard of this phrase in neurology before. But what exactly does this mean? Well, in here, the pupils do not constrict to light, but they do constrict when they are focused on a near object. And why is that? This is because the pretectal nucleus, which handles the light reflex, are damaged, but the Edinger-Wespers nuclei, which controls the near response, are intact. So, light can't trigger constriction, but accommodation still works. Hence, the light near dissociation. Fun fact, this phenomenon is often seen in Agrig-Robinson pupil, aka the prostitute's pupil, but in paranoid, it's a sign of dorsal midbrain involvement, not neurosyphilis. Eyelid retraction. In paranoids, you often see a wide-eyed, startled look, and this is called Kohler sign. It is due to disruption of inhibitory fibers from the posterior commissure to the levator palpebrae superioris, which is the muscle that lifts the eyelid. With this inhibition lost, the levator fires excessively and the eyelids pull up too far, and this is why the eyes look unusually open. Next is skewed deviation, and this one is a little bit sneaky. Skew deviation is vertical misalignment of the eyes due to disruption of vestibular input to the ocular motor nuclei. The midbrain tegmentum helps to integrate vestibular signals to maintain eye alignment, and damage here will cause imbalance where one eye drifts up and the other looks down. Pretty weird, right? Well, that's skew deviation. So, let's put all together. We have upward gaze palsy, which means the rostral interstitial nucleus of the medial longitudinal fasciculus and posterior commissure are damaged. We have convergence retraction nystagmus, which is due to disinhibited convergence response. We have lightning dissociation due to pretectal damage sparing the Edinger-Westphal nucleus. We have eyelid retraction due to loss of inhibition to the levator palpebral superioris. And we have skew deviation, which is due to imbalance in vertical gaze from the vestibular input. All road points to the quadrigeminal plates, the dorsal midbrain, often compressed by a pineal tumor or, like we said, an infarct. So, next time you see eyes that won't go up, pupils that don't respond to light, and a wide-eyed stare, think Parinaud syndrome. Back to our question. Our answer: quadrigeminal plates, aka the dorsal midbrain. Please do not fall for option A, which is the ventral midbrain. We'll talk a little bit about pathologies that occurs in the ventral brain in a future podcast. Next question. A 53-year-old woman who underwent coronary artery bypass surgery 5 years ago develops acute onset of right hemiparesis and aphasia. As per the nurse, the patient had shaking of her right arm just prior to the onset of neurological deficit. A brain CT scan obtained 30 minutes from the onset of symptoms shows no hemorrhage and no evidence of acute stroke. The patient's blood pressure is 170 over 100 millimeters of mercury and her blood glucose is 48 milligram per day. The National Institute of Health Stroke Scale (NIHSS) score is initially 16 prior to the CT scan, but the second evaluation after the scan and correcting the hypoglycemia demonstrates improvement with NIHSS score of 3. A decision is made not to give her intravenous tPA. Which of the following is not a contraindication to give this therapy? A. Major surgery within the last 14 days. B. Seizures at the onset. C. Rapidly improving or minor symptoms. D. Glucose less than 50 mg per day. And E. CT scan of the brain showing no evidence of acute infarct. What do we think? Now, like always, we're going to first analyze this question and then we're going to unpack it. This question talks about a 53-year-old woman who is 5 days post coronary artery bypass graft surgery. We are told that she develops right-sided weakness and aphasia, which are classical signs for a left hemispheric stroke. But here's a twist. The nurse notes shaking of her right arm just before the neurological deficit appeared, and an urgent CT scan was clean, showing no hemorrhage and no obvious infarct. Initially, her NIH stroke scale score was 16, which indicates moderate to severe stroke, but after treating her low blood sugar, which was just 48 mg per day, her NIHSS score plummets to 3. That dramatical improvement led the team to withhold tPA. So the question is, which of the following is not a contraindication to giving that tPA? Well, the obvious answer is CT scan of the brain showing no evidence of an infarct. And here's why. First, let us discuss about the NIH stroke scale and what it really tells us. The NIHSS is a systematic 15-item scale that neurologists and emergency medicine physicians use to quickly assess the severity of a stroke. It evaluates the following: level of consciousness, best gaze, visual fields, facial paralysis or facial palsy, motor strength on the upper and lower limbs, limb ataxia, sensory loss, language, dysarthria, and extinction or inattention, also known as neglect. And each item is scored and the total ranges from 0 to 42. A score of 0 tells us that there are no stroke symptoms. A score of 1 to 4 indicates minor stroke. 5 to 15, moderate stroke. 16 to 20, moderate to severe stroke, and 21 to 42 is severe stroke. So, when these patients caused 16 initially, this suggested a moderate to severe stroke, and she typically qualifies for an IV tPA, assuming all else checks out. But here's where things became a little bit dramatic. After correcting the hypoglycemia, her symptoms improved, and her NIHSS score drops to 3, suggesting a minor stroke. Here's the dilemma. tPA is time sensitive and can reverse disability, but only if the benefits outweighs the bleeding risks, and minor or rapidly improving symptoms are relative contraindications. What's the concern? Giving a powerful thrombolytic when symptoms are resolving could expose the patient to intracerebral hemorrhage with little clinical gain. So what's a clinical peril? Always remember to check the blood glucose before giving tPA. Hypoglycemia can mimic stroke, and in this case, correcting the sugar turned a 16-point stroke to a 3.1. Back to our question. Let us review the contraindications listed. Major surgery within 14 days is a relative contraindication. Seizure at onset. If post-ictal symptoms mimic stroke, be cautious. Rapid improvement of symptoms is also a relative contraindication, and a glucose less than 50, exclude hypoglycemia before treating. So our answer is E. CT scan of the brain showing no evidence of acute infarct. That's actually a requirement, not a contraindication. You want a CT that's free of bleeding or established infarction before giving a tPA. Let's recap. In stroke codes, NIHSS isn't just a number, it is a clinical compass. It guides you through the fog of uncertainty, and it helps you to make that decision. Who gets a tPA and who doesn't? A high NIHSS suggests more deficits and greater potential benefits for a tPA. But if the score drops quickly, or if symptoms are minor or fluctuating, the risks may outweigh the benefits. Also, don't forget the stroke mimics, like hypoglycemia and seizures before reaching for that valve of outer place. Next question. A 50-year-old man has a history of stroke in the right MCA distribution. The MRA shows a severe stenosis of the right MCA. As initial therapy, which of the following treatment options has evidence to support its use? A. Surgical bypass. B. Angioplasty. C. Stenting. D. Warfarin. E. Aspirin and Plavix. What do you think? This is our final case today, and it brings us to a 50-year-old man with a history of right middle cerebral artery stroke. His MRA shows severe MCA stenosis, and now the question is, what is the evidence-based initial therapy to prevent another stroke? The correct answer is E. Aspirin and Plavix. Let's dig into the why, because in stroke medicine, more intervention doesn't always mean better outcomes. Intracranial atherosclerotic disease is one of the most common causes of recurrent stroke worldwide, especially in Africa and Asian populations. It involves narrowing of the arteries inside the brain, often due to high cholesterol level, hypertension, diabetes, and smoking. When an artery like the MCA is severely stenosed, we are talking about 70 to 99% narrowing. The risk of another stroke is pretty high. So the natural instinct might be, let's open it up, let's do a bypass, let's stent it, or let's balloon it. But here's what the evidence says. Here's the SAMMPRIS trial. SAMMPRIS stands for Stenting and Aggressive Medical Management for Preventing Recurrent Stroke in Intracranial Stenosis. And this trial shook the world of neurology. It compared two strategies for patients like ours. The first, aggressive medical therapy alone, and the second, stenting plus medical therapy. For aggressive medical therapy alone, what were used includes high-dose statins, dual platelet therapy including aspirin and clopidogrel for 90 days, tight blood pressure control, tight diabetes control, and lifestyle changes. What exactly happened? The stenting group had a much higher rate of early stroke and death, and the medical therapy group did by far better they had fewer strokes and fewer complications. All of this translates to medical therapy was not just safer, it was superior. Now, the question is, why is stenting risky in the brain? Unlike coronary arteries, cerebral arteries are delicate and unforgiving. Stenting them can cause pre-procedural strokes due to 1. Microembolization, 2. Perforating artery occlusion, and 3. Dissection or rupture. The MC in particular has many tiny perforating vessels that supply the deep brain structures, and stenting risks blockage of those critical feeders. So, unless someone is failing maximal medical therapy and has recurrent ischemia, stenting is generally not recommended. So why aspirin plus clopidogrel? This dual platelet combination is well studied. It reduces platelet aggregation and it has been shown to lower stroke recurrence in short term after a high risk event, especially when started early and continued for 90 days. After that, long term aspirin monotherapy is usually resumed. What about other options? Surgical bypass. Historically, this was used, but trials like the ECIC bypass study showed no benefits and even shows that they may be worsening outcome. Angioplasty alone, well, there is no strong evidence for this, and we even have risks of vessel recoil or even rupture. What about warfarin? The WASID trial compared warfarin to aspirin in intracranial arterial disease and showed no benefits and even a higher bleeding risk in the warfarin group, particularly intracerebral hemorrhage. And lastly, stenting. As we said, it's not the first line. It is reserved for selective cases under research settings or clinical trial. Our clinical takeaway. In intracranial atherosclerosis, aggressive medical therapy wins. What does this mean? It means aspirin plus clopidogrel for 90 days, a target LDL of less than 70 mg per day with a statin, systolic blood pressure of 140 millimeters of mercury or less than 130 in diabetics, tight HbA1c control, smoking cessation, exercise, and diet. This isn't just conservative, it is high impact brain protecting therapy. So, here's our recap. In a patient with severe symptomatic intracranial MC stenosis, skip the stent, drop the scalpel, go with dual antiplatelet therapy and aggressive risk factor control. And that's because the SAMMPRIS trial shows us that when it comes to stroke prevention, less can be more. That was a lot. I hope you're not sleeping already. If you were, just hit the snooze button so we can do a little rewind and lock in all we've learned. 1. Parinaud syndrome refers to upward gaze palsy plus light near dissociation. When you see that, think quadrigeminal plate involvement, which is the dorsal midbrain. 2. Normal CT does not equal to tPA exclusion. The real contraindications include hypoglycemia, that is low blood sugar, recent surgery, seizures at onset, and minor or rapidly improving symptoms. And lastly, when you see an MC stenosis, the best evidence is for aspirin plus clopidogrel, not stents or warfarin. Think SAMMPRIS. That's a wrap for today's neuroclarity round. Fast facts, clear thinking, and smarter neurology. If you found value in this episode, help us grow by subscribing, rating, and liking. Do you have a burning case or board question you want us to feature? Drop your comments in the section below. Until next time, stay curious, stay sharp, and keep your neurology clear with neuroclarity. Bye for now.